April is Autism Awareness Month. Early childhood educators and providers can play an active role in supporting children with autism spectrum disorders and other developmental disabilities and their families by using developmentally appropriate practices, engaging families, tracking developmental milestones, and sharing community based resources. Tonight's webinar topic is Autism and Vision Therapy. Our webinar is hosted by Dr. Ken Westcott, OD, from Developmental Vision Care. He has been helping children and adults in the Hampton Roads area of Virginia meet their visual needs for over 20 years. His practice provides vision therapy to patients who range in complexity from computer eye strain and learning related vision problems to patients with autism, strabismus, amblyopia, or those who have suffered a concussion, traumatic, or required brain injury. He continues to study and research best practices and is an active member of the Neuro Optometric Rehabilitation Association, the American Optometric Association, the Virginia Optometric Association, the Tidewater Optometric Society, and Parents Active in Vision Education. At this time, I'd like to welcome Dr. Kenneth Westcott.
Thank you, Lily Eunice. That's a mouthful, all those names and things like that. I'm so excited. I so much miss the get-togethers that we used to have at the Parent Resource Center, and I'm hoping that as things progress, that we'll be able to get back together again. It's so fun. This talk particularly is so fun to give. There's so many examples that we can give in person, but it's hard to convey that over the internet. But I'm so thankful to be able to present. I want to start, I'm going to switch to my screen. There. And tonight I'm going to talk about not autism spectrum disorder, but vision and how it affects people that may have been diagnosed with autism. I want to start reading from a book. It's called Look Me in the Eye, My Life with Asperger's by John Robinson. This was written several years ago and as an adult with autism. And it really describes things well. It says, it starts off in the prologue with, "Look me in the eye, young man. I cannot tell you how many times I've heard that shrill, whining refrain. It started about the time I got to first grade. I heard it from parents, relatives, teachers, principals, and all manner of people. I heard it so often that I began to expect to hear it." And then later on in the book, he goes on to describe this, and exactly what we're going to talk about today. It says, to this day, when I speak, I find visual input to be distracting. When I was younger, if I saw something interesting, I might begin to watch it and stop speaking entirely. As a grown-up, I don't usually come to a complete stop, but I still may pause if something catches my eye. That's why I usually look somewhere neutral at the ground or off into the distance when I'm talking to someone. Because speaking while watching things has always been difficult for me. Learning to drive a car and talk at the same time was a tough one, but I mastered it. And he goes on, it's a wonderful book just to hear an adult describing some of the things that we're going to talk about tonight. And one of the best terms that I've heard associated with that, and it's not just with vision, it's pretty much all sensory input, is something called sensory incoherence. From a visual standpoint, if you're watching a movie and it's out of sync, the voice is out of sync with the mouth with the words, they're just not working together. Even anybody would look at that and you just find it very uncomfortable. It's actually harder to hear what they're saying because the mouth is moving differently than the words that you're hearing. And think of this, vision is the only one of our senses in the whole entire body that requires exquisitely accurate muscle control in order for the information to be coming in through my eyes to make sense and be consistent. Well, what I'm going to talk about today, actually, let me go through this. So there are many symptoms that are highly associated with autism spectrum disorder. I'm not going to go through these all because we're going to talk about some specifically, but I want to put it in. If you want to go back and look on YouTube, you can go through and review this a little bit quicker. But gaze aversion, that avoidance of eye contact, kind of lateral viewing where people will look out of the corner of their eye. Visually, there can be reasons why a person would do that. Distorted body postures, toe walking, touching surfaces a person moves through space to help them figure out where their body is in space. Spinning objects, the finger flicking the stems that some people will use. We actually use that in therapy for a reason. I'm going to go in a little bit more specifically about visual symptoms that are actually included in the screening and diagnosis of autism spectrum disorder. And again, this is poor eye contact, and that can show up. What John Robinson was talking about is just avoiding looking in an eye. Sometimes it's hard to look and think at the same time for certain people, and that is one of the reasons visually that you may see avoidance of eye contact. And that lateral viewing, we'll talk a little bit more about vision before I go why, and we see that in certain individuals. They may like to line up their toys and have order, but for very specific reasons. They may not follow, you're looking, hey, what's this? And they may not use their eyes, or they may not have the cues to look at where you're looking to help them understand what you're saying. The stimming we talked about. And then also they just may kind of stare off to space, shutting off vision. What I want to do today, before we go back and talk about why that would be going on, is get a better understanding what vision really is. I also want to talk about the developmental process that we go with vision and a bit on what goes wrong. And this is not just people with autism, but the patients that I deal with. What can go wrong in that developmental process that interferes with that? Before we go to that, think about how much we use vision. Estimates show that about 80% of what we learn in a classroom comes through vision. And it's amazing how much we use our eyes. In this time, over 300,000 books are published each year. And just in general, this is before the pandemic, the average teenager spends at least 7 hours a day on screens at school, on their phone, and that number is probably substantially higher. We've actually seen a higher rate of increase in not only people becoming more nearsighted from all that near work, up close, that near stress, but also children where their eyes will actually start to turn in when they develop something called an esotropia, because they're working so hard up close. Their body doesn't like it, and that's one of the ways they adapt to it. Well, let's talk about what is vision. Typically, when I'm in a group, I'll say, what is vision? I'll pick on somebody that has glasses and ask them, well, what does it mean if you go to the eye doctor and say, Mrs. So-and-so, you have good vision? And what will typically come up is, I can see good. And that's what most people think of. And even eye doctors think of that. When you go for a basic eye exam, what you're looking for is, are the eyes healthy? Can the person see clearly? And do they need glasses? Are they nearsighted or farsighted? Do they need something to help them to see clearly and comfortably? But think a little bit beyond that. I look at vision as a process that we use to kind of store, identify, compare, organize, interpret, understand what I'm seeing. This is very important. Our visual process creates this internal perception of the outside world that we use to guide our eyes, hand, or whole body through space. And remember, vision is the only one of our senses that requires exquisitely accurate muscle control in order for that information to come into the eyes and make sense to me. If I have trouble with muscle control, as we'll see, that can make it hard for me to point my eyes and get good solid information in. So the moral of the story is that vision is much more than 20/20 eyesight. Eyesight is just a small subset of that whole process. I kind of look at vision and break it down into two artificial groups of skills. You've got skills that help me get information from the world through my eyes back to the brain. We call them visual intake skills. And so this is where, are my eyes healthy? Do I need glasses? The numbers over to the side were from a study conducted a few years ago, looking at people with autism and just seeing how often does this happen. And about 44% of people with autism require some kind of optical correction. This is a big one, fixation. Fixation is the ability to pick a spot and look at it and sustain looking at it for as long as I need. And people with autism tend to have a problem with fixation. That's called fixation dysfunction. About 78% of people have trouble with fixation. We see it in people that aren't diagnosed with autism too, very commonly, and it almost always makes it very difficult in the classroom. We're going to talk a lot about fixation. Another thing that we look at is something called eye teaming. Now, this is not necessarily part of a routine eye exam. A routine eye exam, again, is looking, are my eyes healthy? Do I need glasses? Can I see clearly? Eye teaming is the ability of the brain to take the right and left eye, put it together, get eyes pointed at the exact same spot, and so what I see makes sense to me. Now, there's a large range in this over several different studies. Some studies have found it as low as 21%, which is still a pretty high number, up to 84%. And it really depends on how you define eye teaming. If you look at an eye turning in, like something called an esotropia, or one eye's going outwards, walled eye, that's called an exotropia. That's going to be that lower number. When you look at just, I'm not very good at using both eyes together. I'm kind of like how you can have a child that's uncoordinated in walking and movement. You can have a child that has trouble coordinating right eye versus left eye, so they have a hard time getting both eyes on the same target. And another one is called visual tracking. Now, we actually prefer the term eye movement control, the ability to pick a spot, and when I'm reading, jumping to the next word, so knowing where I'm going to move my eyes to next. Or there's another type of eye movement called a pursuit eye movement. That's the keep my eye on the ball type of eye movement. And another one called near focusing. Now, that's not the ability to concentrate up close, but there's actually a little lens inside of my eye that changes shape to see clearly when I want to see something up close, and then it should relax so that I can see it clearly off in the distance. Now, this is another really important point to really think about. If I'm growing up and I'm not good at putting my eyes at what I want to see, if instead of the two eyes working together, they're interfering, so what I look at up close is stressful, it's hard for me to stay engaged with things up close for long periods of time. What'll happen is I tend to look at something up close and then it becomes stressful. And so then I'm distracted by, oh, what's that out there? Or I want to talk about something rather than stay engaged on task. And again, this is not just true in people with autism, but other children, when they have this, will typically spend less time staying engaged with things up close. So going back to that first example of learning to understand, remember, store, process what I see, if I'm spending less time looking at something up close, then what happens is I spend less time doing that compared to a child that's developing normally. And so I will tend to have trouble with visual processing. Now, unfortunately, I've got so much that I want to go through. I normally spend about 2 hours on this particular talk just because I love going into detail, because I find I get such good feedback from parents or just families that have a child in this category. They get so much information from it. But visual processing, the visual spatial awareness, knowing where my body in space is, that's part of knowing which way a letter is that a D or a B. That goes back to visual spatial awareness, visual analysis, the ability to kind of compare likes and differences. So that helps me in remembering what I call remembering the look of words. Good readers, I'm not anti-phonics at all, but after a while, what happens is a good reader just remembers what that word is. So it goes through a faster process in the brain and helps them to be a good reader. Well, having a good visual memory helps me to remember what those words are and help me spell. Visualizations are really important, and that's the ability to get pictures in my head. Can I get a picture in my head to help me remember what I read? Can I manipulate those pictures to help me solve math story problems? Or all your higher level sciences are really math word problems. You read the words, you convert the language into this imagery that helps you come up with a plan of how to solve that problem. And then, of course, visual motor integration. So that's your eye-hand coordination. So different professions look at it differently. If your occupational therapists are looking at more at finger control, our muscle strength, which is really important. Our OT friends are wonderful helps with that type of thing. But my approach is to actually teach the eyes to guide the hand. And that goes back to the fixation, which I'm going to talk a lot about that, because that's huge. If you can't point your eyes at something, you're going to have a hard time telling that pencil, your visual system telling that pencil where to go. So if you have a problem with visual intake, it's not uncommon that you'll have trouble with visual processing. In fact, very often when I have a child sent to me by the school system where they have a visual processing problem, you look deep enough, you'll oftentimes find a visual intake problem there. So the working definition that we use for vision in our office is vision being the deriving of meaning And direction of action is triggered by light. So that information coming in through the eyes, I'm going to use it to help me understand what I'm seeing and to guide my eyes, hand, and whole body. So I wish we were here as a group because this is so much fun to do. And so you can try this at home while I'm talking. But what I want you to do is try to stand on one foot. And I can't do it in the room that I'm in here. But if I stand on one foot, what I want you to do is stand on one foot and just notice how that feels. And now what I want you to do is close one eye. And when you close one eye, most people notice that they tend to be a little bit wobblier with one eye as opposed to two. Well, why is that? You can see clearly. It's just wobbly with one eye. We'll talk about that. And this is a really neat one, but listen carefully to how to do this. What I want you to do is make a pinhole. So close one eye. You can do this without glasses. And I want you to make a little pinhole with a hole in your fingers, just rolling it up like this, and put it right, mash it right up in front of the eye so you don't even see any light coming from the side. That's important. When you do that, you can still see clearly, but if you're standing on one foot, you'll find it very difficult to maintain your balance with one eye closed, even more so than just one eye closed. And you can still see clearly. In fact, if you're looking through a pinhole, you'll often see clearer clearer than without your glasses. So it's clearer, but you have trouble with balance. And I want to talk about why that is. Part of it is what's called the retinal collicular pathway. Now, when we're thinking of vision, most of the time we're thinking of that optic nerve going from the back of the eye through an area called the lateral nucleus to the back of the brain, the occipital cortex. That's the part that we see with. Really important because we're going to talk more about that. But this retinal collicular pathway is, I think we're working on that more in therapy, particularly in the beginning stages, to help people with balance and mobility issues. This retinal collicular pathway breaks off from the optic nerve and actually goes to a part of the brainstem called the superior colliculus. And it's a very fast operating system. It works much faster than the part of the brain in the back that we see with, but it helps me create this spatial map of the world. And it's almost like this internal GPS that helps me understand where space is, where my body is in relationship to things in the world. Let's do another example. So oftentimes we'll have a patient complain that when they read, children will very rarely complain of seeing double. And if you ask it carefully, when you're looking at something, did the words ever accidentally come apart? When you're looking at something, does it accidentally come apart? That's double vision. And say, oh yeah, that happens. Does it happen when you first start reading or after you've been reading for a while? Oh yeah, when I read for a long time, like 5 minutes, it'll start to do that. Or when you read, do the words do this kind of thing? It's very often, I saw a young man this morning, and it was so interesting. He had been seeing this his whole life, and he had no idea of how to explain it. It was just normal for him. And when I said, when you look at something, did the words ever pull apart? Well, I was a little bit skeptical just because it's like, yeah, this is a problem, this is a problem, this is a problem. And mom's like, I'd never heard of that before, but we did some tests. It actually showed that he was looking up close, he would see double. Well, there's an eye teaming problem called convergence insufficiency. And what that is if you watch my eyes, I'm going to come in closer. As I bring my finger in, see how my eyes are turning in to look at my finger? That's called convergence. And so when I look at a book, both eyes have to turn in just a little bit to line up on the page or the computer screen. And then when I go to look far away, they have to diverge to look at something off in the distance. Well, what happens with this convergence insufficiency, if that little egg over on the left side is the left eye and the right eye is the other one, both eyes should point at the exact same point in space. So what you see in your mind is just this word. Well, what happens if I'm not aware of where my body is in space is, or I'm confused about where the thing that I'm looking at is? That's kind of the origin of these eye teaming problems that I was talking about earlier. So let's say I'm looking at a book. I'm going to do it sideways here. This is the book. I'm looking at it, but instead of here, my brain thinks it's back a little bit further. So if the book's here, but my brain thinks it's here, what'll happen is each eye hits a little bit of a different piece of the page. So what the right eye sees doesn't sync up with the left eye. And that's what we call an eye teaming problem. What I see in my mind is this confusion. It's not actually necessarily two books, but oftentimes it's like stuff on top of the stuff. So that's where the kids will complain that they see this. Or another one that they'll say is the words seem like they're floating or moving on the page as they read. This is exactly what's going on. So it's a little bit confusing unless you deal with this every day, because a lot of doctors think, oh, it's a muscle problem because the eye muscles aren't strong. And what Dr. Westcott's doing is it's kind of like going to the eye gym and you're doing these exercises to strengthen the eye muscles. And thankfully, that's actually not what we're doing. If it was, and you stop doing the therapy, well, then a month later, your eye muscles are flabby again or something, and then you have the same problem. And we just don't find that as an experience. So let's go back to that original. What should happen is both eyes locked in that same target. In the brain, there's this process called summation. And I always describe it as like what the right eye and the left eye see is when it comes together, it's almost like 1 + 1 = 50. And that's very true. There's so much more information that comes from the brain using both eyes together than you'd predict from each eye individually. And you actually can measure that in the brain, where the brain actually picks up a stronger signal than just 1 + 1, because the brain's using both eyes together more efficiently. So that's eye teaming problems. Another one that we talked about was that fixation. Well, part of that, the ability to see something up close, well, now when I'm looking at a book, that little lens inside of my eye has to change shape to make what I see clear. But even more important, to see clearly, I have to be able to fixate. I have to lock in that eye right on target. The way the brain is laid out, this is so interesting. Remember, 78% of people with autism have trouble with fixation. And that's just the ability to pick a spot, look at it, and keep watching it. And one of the tests that I do almost from the beginning, after we've talked about what's going on with the child, is I have them look at this little target up close, little ball and a stick, and they'll look at it, and you'll see them look at it, and the next thing you know, they're looking away, and you get their attention, and they'll look at it, and then they're looking away. I want to see somebody be able to sustain that for 10 seconds. Even your child with the most severe case of ADHD can pull it together and look for 10 seconds. And you'll oftentimes see that you'll have somebody that can fixate a letter far away forever, for 20 feet, no problem. They look at something up close, and that's where they have trouble. Well, that could be that looking up close at that near target is stressful for me, like that eye teaming problem. So sometimes a problem with fixation is just that this is stressful for me. With people with autism, there's a lot of research going into this because it's such a prevalent problem. And if you think about it, the brain, so if you hold your thumb out at arm's length, just that area of your thumbnail takes up about 1 degree of visual space. Well, in the brain, that 1 degree of visual space takes up 4 square centimeters of brain in the back of the eye to understand that one little spot here. That is huge. In neurology, that is a large amount of information that's going from the optic nerve going to the back of the brain. That takes up a lot of information. Well, it's also very overwhelming. And remember, with fixation, if my eyes aren't teaming together, I have to fixate exactly with the right eye and the left eye in the exact same point in space. And if those two eyes aren't working together to work together synergistically, that can create that interference relationship that makes that very stressful. And not with every child with autism, but very commonly, if they have a problem with eye teaming and fixation, as you work on that, we always work on fixation first. You want to be able to point one eye first. If you can't do it with one eye, of course you won't be able to do it with both eyes together because it's much more complicated. But think of how much brain's going to that. If you go out 6 or 7 inches from that other one, so I'm looking at my right thumb here, and this area out here, that whole area of my thumb now out here in the periphery takes up maybe 1.5 millimeters spatially in that spatial map in the back of my brain. So it's very much less information. What if I'm overwhelmed by what I see? It's visually overwhelming for me, like John Robinson was talking about. That big area of brain that's processing all that information is a very strong signal. And so would that be a reason that I tend to avoid fixation? It's hard for me to get both eyes on the same target. What I see is confusing. It's hard for me to look and listen at the same time. So I'm just going to take that out of the picture. And you'll oftentimes see that where it's like when they look me in the eye, you tell them to do that. And it's almost like they can't hear what you're seeing. It's like for anybody, it's always hard to do two hard things at the same time. So if it's hard for me to listen and understand what you're saying, and it's hard for me to point my eyes and look at you, I'm not going to do 2 hard things. So if you want me to listen to me, okay, I'm taking vision out of the picture, or I can look at you and pretend I'm listening, but that's all I'm doing is pretending to listen. And there's actually a study that came out, I think in about 2014. It's really exciting because when they looked at children with autism In that central part of the brain, that 4 square millimeters of brain, centimeters of brain, they found that children with autism and a child that was developing, I hate to use the term normally, because that's not normal. Most children are all a little bit different, but they were using that central part of the brain. The activity in both of those areas when they were fixating something was pretty equal, which I found that interesting. But where they found a difference is that peripheral activity was much higher in children with autism. And part of what's exciting about that is that gives us the potential to screen children earlier. Now, unfortunately, this study looked at children that were older, probably like 11 to 17, and the study group was children that were higher functioning. And so we really need to look at that with younger children and children with more severe autism. Now, that test is a little bit hard to do because you need them to look at something. And if I have severe problems with fixation, I don't do it. But we have pretty sophisticated eye tracking technology. Well, something even a little bit simpler is a test. This isn't just an observation that's been found, is even in very young infants, children generally are attracted to faces. And so they did a study, this was in 2011, and they looked at children with autism. And again, the children that didn't fall in that category. And they found that children with autism tended to prefer looking at a geometric shape as opposed to looking at faces. And this is a very young age, and it's a relatively simple thing to test, is what do you tend to look at? They did another study again later, and they looked at what's called a dynamic geometric shape. So this is like a geometric shape that's actually has some motion to it. And then instead of adult faces, they looked at children that were doing kind of interesting movement things and interesting, faces of children. And again, the same thing, that group of people that were diagnosed as having autism were much more attracted to the geometric shapes as opposed to the children moving and their facial expressions. And so that's very interesting because that may be a tool in the future as really a screening and maybe even a diagnostic tool to be able to pick this up earlier. And wouldn't it be exciting to know at 1 or 2 years old that this child is at risk for autism? Because think of what we could do if we could start speech therapy in that at-risk population earlier. I think that would make a big difference. So again, not really involving me, but that early detection of the issues is really exciting. So there's a lot on the horizon that I think we'll see with that. Sorry, that was off on a tangent. So back to fixation. 78% of children have trouble with fixation. Fixation, though, is a learned skill. We see children of all makes that have trouble with fixation. And it's one of the first things we start working on. What's exciting about that, sometimes it's easy to fix, sometimes it's really hard to fix. And I haven't found a predictive tool to figure out what's going to be the easy case versus the hard case. They prove me wrong. So I'll take this child and oh man, this is going to be really tough. And like a month later, it's like, oh, you wanted me to look at it? Boom, and it just locks in. It's not a cognitive thing. It's like, oh, I get it. Why would I not want to look at somebody when they're talking to me? I get so much nonverbal information by looking at facial expression, things like that. And yes, there's social things there that maybe that's overwhelming to a child, but maybe I don't fixate because it's hard for me to look at that. And so that's why I voice guys contact. And when we see that being true in our population, not every child that we work with, but very often, most patients will show an improvement in fixation. And again, sometimes I think the easier ones are the ones that when the eyes start working together as a team, it's easier to get my eyes on target. I get so much more information out of that using that 4 centimeter area of my brain that I want to use that. Another reason that children will lateral view, so that's gaze aversion that we talked about, lateral viewing. If I stretch my head over here, when I look at the camera and I close my eye, there I go. I can't see that camera any longer with my left eye, and I can see it here with my right eye. So what I'm doing is I'm actually keeping my eyes from interfering with each other because I'm looking with just the one eye. So you'll see some children that'll close an eye or put a hand over an eye when they're doing a visually demanding task. Well, sometimes that gaze aversion can be my way of keeping the eyes from working together as a team, to keep them from interfering with each other. And fixation dysfunction always interferes with learning. When that gets better, it almost immediately transfers in the classroom. And think about it. One of the examples that I often use, if I don't fixate, I don't use vision to guide behavior. I'll say, hey, Billy, what's this? What's this over here? I don't know. What is it? I don't know. Look at it with your eyes. Boom. I'm asking this visual question. Hey, what's this? The only way to answer that is for me to point my eyes at the target. And you actually have children very commonly that, what's this? I don't know. And you actually have to tell them, hey, take the tool, use your eyes, look at it with your eyes, and now tell me what it is. The reason they're not using that is possibly something called fixation dysfunction. Okay, well, let's go on. Where does vision come from? So are we born with vision? We're born with a body, we have eyes, and we have a brain, but that brain is almost like a computer with no software on it. And what we do is we have these God-given pre-programmed reflexes on the brain. They're referred to as infantile or primitive reflexes, and they help that human infant to learn to interact with the world. And wouldn't you know, people in that population with autism tend to have a higher rate of retained reflexes. So oftentimes it's a good idea to work with an occupational therapist that's trained in that, because those reflexes are the starting blocks to help me learn to use these tools. We'll talk more about that. Well, do we grow as we get bigger and our body gets bigger? Do we grow vision? Well, that's obviously no, but it's this process of development. Development is a step-by-step process that all human beings go through. And I want to talk about what that looks like. But think of this, vision is developed by movement and touch, interacting with the world around me. If you took two lab rats and you put one in a cage and put them in front of a screen and have them watch that screen all day long, and you let another one of those rats run around the laboratory, I mean, it's pretty obvious that they're going to develop differently. Well, we do that with children too. If they spend too much time on their iPad, and I know that's an important communication device, it's not just people with autism. Children in general are glued to those iPads. Well, it's almost like developmental poison. If they're sitting here doing this all day long, they're not out there playing. And that outside play is almost like an antidote to that screen time up close. And with this COVID thing, outside play is so important. Well, how I look at development is I tend to look at it as this upside down pyramid. So again, you're born with a body and a brain. And what happens is you interact with the world, you use these reflexes, and you start developing more and more sophisticated behavior. So it looks like this upside down pyramid. So the baby comes out of the womb and they put their first block in that upside down pyramid. Well, then they use that block, the reflexes, they interact with the world, and they put more sophisticated blocks on top of it. And so the next thing you know, your child's 8 years old, they're tooling around with blocks up here. But this is important. How these blocks up here work are foundationally dependent on the blocks that come down below here. So if this block is missing down here, I may still be able to do this, but I've got so many workarounds, it's hard for me to sustain that for long periods of time. And so that's what development is. And so I want to talk about it. Now, teachers will oftentimes talk about learning style, but if you think about it, there's this natural progression that I go through on what tool I use the most to get meaningful information from the world. And I say oral here, but oftentimes, just as I'm generally talking to a more sophisticated group with parents or people that work with children with autism, I think it's actually the vestibular system. The vestibular system is the only one of our senses that's actually myelinated. It has the fatty insulation on those nerves to help that system be up and firing even before I'm born. I think that helps with the birth process, the baby getting into position. I come out of the womb, then it's smell. It's like, I'm an infant. I don't even understand the concept of mom, but you don't smell. Oh, yeah, you smell right. That's exactly what I want. They're really tied into smells, but then all of a sudden it becomes oral. That child doesn't even have the motor skills to pick up the block. That young infant will fall over, put their mouth on it. And it's not necessarily that they're hungry. I mean, that's a big part of their day. But when it goes in their mouth, that they can just wrap their mind around it. They understand that. Well, after oral, what happens is I have this exchange between hand. I pick up the block. Where does it go? It goes to my mouth. So I'm still an oral explorer, but given time and necessary and meaningful experience, all of a sudden I'm a tactile explorer. So this is a child that comes into a new environment and I must touch, I must touch, I must touch. And the reason they do that is they're getting meaningful information. It makes sense when they touch it. They need to feel it to understand it. And there's a lot of patients that we're dealing with in vision therapy that are kind of stuck in that tactile exploration. This is a child that when they go to count, they have to get their fingers out. They need a tactile manipulative to help them know what 5 is. After tactile, then communication starts. Okay, many of the children that we have in our autistic population tend to have trouble with communication. Auditory, speech and language is a big issue. Auditory processing is important. And so what happens is I have problems with communication and auditory processing. That information coming into me is confusing. It's overwhelming. I can't make sense of it. So I'm going to ramp down to being either a tactile explorer or sometimes oral explorers, where everything that goes, where does it go? Right in their mouth. The child will tell you what tool they're using to explore the world. Well, in a normally developing child, what happens is oral, tactile, auditory, then we want to see vision become the dominant tool. And that's somebody that uses vision to guide action. They pick an area of space from which to get meaning and direct action to. And it's the most sophisticated. If I have trouble with vision, then what happens? I become that auditory learner. And I want to show you what that looks like. So let's talk about what can go wrong. We call that in vision therapy a learning-related vision problem. And so one of our pioneers, his name was John Streff from Lancaster, Ohio. I'm always quoting this. This makes perfect sense. When vision's working properly, it instructs and leads. When it's not working, it interferes. And so I'm getting it out of the way because I'm overwhelmed. It doesn't make sense. It's too much brain. I need to shut it off. I may be going with a different tool. I need to get vision out of the way so I can make sense of what I hear. Or I need to get communication out of the way. I'm overwhelmed by sounds. So then I'm going to be that tactile explorer. It's got to go in my hands for me to even know that it exists. Well, let's look at a muscle sequence and just watching children grow. This makes sense to you. That baby comes out of the womb. The first muscle group that they get good control is oral motor for latching on, eating. And then we want to see that child start crawling. Crawling developmentally is so important because it's the first time that my brain has to figure out how to coordinate the right side of my body versus left side of my body. And not only that, but upper body versus lower body. And what happens is if I have delays in that, I have a poor sense of laterality, this internal sense of left and right. And therefore, when I go to look at a D or a B, I don't know which way that is. I can't look at that and tell you that's a D. I have to go through some kind of thinking process, say, oh, that's a circle stick, so that's a D, rather than just looking at it and knowing it. So if I have delays here with laterality in my body, then I have a hard time projecting it out in space, and so I don't have good directionality. After gross motor competency comes fine motor control. And how many children in our population with autism have delays in gross motor? They've been in physical therapy. When you have delays in gross motor, you're almost always going to have trouble with fine motor skills. When you have trouble with that, it's very common to have trouble with superfine muscle control, which is your eye movement skills, the ability to point your eyes. Again, that's the most basic eye movement skill. It's just to pick a spot and look at it. If I can't do that, then I'm going to have a hard time following the object. I'm going to have a hard time keeping an eye on the ball, catching that ball as it comes to me. I'm going to have a hard time when I'm looking at one word, knowing when to get and move my eyes to next. Now, one of the things that's so fascinating is oftentimes people that are classified as kind of high functioning, and what that is, they may have trouble with like eye teaming, their body position space, but these kids love to read. They're so smart, they figured out a way to work around it. So what they do is they don't have to figure out where their body and space is. They just lay down on the floor so they don't have to post gravity. So they love to read, but it's always laying down in bed where they don't have to sit up at a desk and post gravity. You do this, I'm doing 2 hard things at the same time again. And don't you know it? I'm thinking about I have to think about not falling out of the chair. So it's hard for me to read that way. If I lay down and don't oppose gravity, it's much easier. What can go wrong in this sequence? So again, I talked about that a little bit. If you have good oral motor, gross motor, but some delays in fine motor, what may happen is you, when you go to read, may not be a very skilled eye mover, so you tend to move your head rather than your eyes. And even adults that are head movers tend to complain that the longer they read, the comprehension goes down. On a severe delay, what that would look like is, wow, I can eat, I have good oral motor skills, but I'm just delayed in gross motor. So you see that sequencing, trouble with fine motor, almost always have trouble tracking a target. You'll have a child when hey, follow this target, they're doing it like this. They're using their peripheral awareness, that part in the brain that is overly stimulated in children with autism. They're using peripheral awareness to monitor that ball, but they're not tracking it. They're not looking at it. It's a very different thing. If it's out that far out, I can't see it clearly. And the beauty of the brain is, I don't realize that I can't see it other than I can't read words on a page. Or when I'm looking at you, the whole rest of the room in my brain appears clear, but optically we know it's not, because anything beyond that 1 degree is starting to get blurrier and harder to see. What can go wrong with the dominant tool? What if I have delays in vision? I'm not good at getting both eyes on the target. We call that a learning-related vision problem. And this is a child that's more the auditory learner. They like to listen to auditory books. They like to alternate read, where they read a page, you read a page. And then when they do that, their comprehension is pretty good. If they have to sit there and read a book, again, just like that adult that's a head mover, if they have trouble keeping their eyes together, they're going to deflect out of being a visually dominant learner and tend to be more of an auditory learner. And in the severe cases, what we'll have is that child that can't use vision. It's overwhelming to them. They shut it off. They're not an auditory learner. They have problems with maybe auditory and sensory integration, so they shut that off. So that's going to leave me with tactile and oral is my main way to get information from the world, and you'll see that. So how do we fix these problems? We've got different options. The first thing is having the right person look at it. Now, most eye doctors have heard of vision therapy, but they're not really skilled in it. They tend to think it's more of an eye exercise type of thing. And it's really not strengthening muscles. So you want to find somebody that is referred to as a developmental or sometimes behavioral optometrist, different than behavioral psychology, but that type of person generally is skilled. And I'll give you some resources to find a doctor in your area that'll help in locating someone. Not all eye doctors are trained in learning-related vision problems, though. In most school and pediatrician screenings, they're really looking at just distance eyesight. And again, you can have exquisite 20/20 eyesight, that small subset of vision, and still have very severe vision problems. In fact, many of the patients that we're working with do not need glasses for eyesight because they see clearly, but they sure don't understand what they see. And so the treatment options in our office are what are called compensatory lenses. And that's what you get from your typical eye doctor. We're very carefully measure the prescription just right, so we get as precise as possible to measure, to compensate for that nearsightedness or farsightedness or astigmatism. In our office, we also use something called a treatment lens. And treatment lenses are where we're actually looking at something that I have trouble staying engaged up close. Well, if I look at that prescription for distance, sometimes that prescription for distance can actually make it harder for me to function and stay engaged up close. So what I do is then I want to find a lens that's going to help me maintain my ability to use both eyes together. And that is called a treatment lens. Completely different way to test for it. We actually look at what the distance prescription was and see what can I do to make that function better up close. There's another thing that's really cool in the autism world. You may have heard it about Kaplan lenses or yolk prisms or magic glasses. Now, these don't work for everybody, but a yoked prism, it increases visual awareness. It helps me have a better sense of where my body in space. It disrupts that sense of where my body is in space to where now I've got to kind of mentally rewrite it. And these are really cool. If you look at yolk prisms and autism, magic glasses for autism, you'll find all kinds of interesting YouTube videos on that, where I've seen children that you put these on and all of a sudden it's like they tune in because we've disrupted the status quo and they're having to go outside of ignoring it to try to make sense of the world. And you'll see really interesting effects with this. And again, unfortunately, they don't work with everybody because it's not what the lens does to the person, it's what the person does with that lens, but it's how they tune into it. But we use yolk prisms in therapy to purposely disrupt their system to where they have to kind of rewrite that mental software that we talked about in development to get rid of the bad habits that they've acquired. Vision therapy then is kind of like physical therapy, but for the eyes, but more so the brain. Vision therapy, Ralph Schrock, who was an optometrist up in Northern Virginia area many, many years ago, wrote this definition, which I really like of it. Vision therapy is the arranging of conditions so that the patient becomes aware of new relationships in his or her visual world, and through these new relationships, learn to utilize processes to allow him to extract a greater amount of information in a more efficient manner. And so think of that. Vision therapy as an eye exercises, the procedures that we do, the equipment that we're using are really, it's almost like props in a play. It's designed very specifically to give that child the experience of, oh, I get it. We call that in development, aha, where all of a sudden, oh, I have a sense of where my body and space is now. And when you feel that block in down here, those higher level skills start functioning more efficiently. Another thing that we see, let's go back to that list, those symptoms of visual symptoms that are oftentimes found are used to diagnose or screen for autism, that poor eye contact. Well, do I have poor eye contact because it's difficult for me to look and listen at the same time? Am I overwhelmed by that part of my brain that takes in so much information from such a small area of space that I need to kind of put it in neutral? Do I lateral view because my eyes have trouble teaming together? That child that lines up toys kind of obsessively. Well, if you live in a world where you're constantly in flux, you really don't know where your body and space is. That means you don't understand where things out here. I want to go into a little bit more detail on that. So if I'm going to point my eyes again at something, I need to know where my eyes are looking from. I need to know where the thing that I'm looking at is. Well, what I see as that information comes in, you'll oftentimes hear the eye described as a camera, and that really undersells that process. Rather than a camera, that image, once it hits the retina of each eye, is broken down into a detection of, oh, there's a line, there's an edge, there's movement, there's color, there's contrast, there's an angle. And each one of those different things goes to a different part of the brain where it's analyzed. And rather than a picture, what it does is it reconstructs this 3D world. We call it our space representation. So what any of us see out here is not necessarily what's really out there. It's our representation in that 3D model in our brain. And the center of that sense of that space representation is called my egocentric locus. It's kind of like right here is where it is sometimes referred to as core stability, my solar plexus. There's a bunch of different names for that. So where do I originate from? Well, that's the center of that space representation. And if I'm living in this world where I'm overwhelmed by too much stuff, there's a spatial mismatch of where I think I'm at, where the things in space are, I'm going to be very insecure in that world because I'm going to bump into things. I'm going to have 20/20 eyesight and bump into the door frame. I may be 20 feet in the air and not realize that I'm not 6 inches from the ground. I may have trouble with navigating steps and curves because I can see there's a contrast there. Was that a line or a step? And if I don't have a good sense of where my body and space is, I'm going to have a hard time knowing how to navigate that space. And so we'll see that. And again, sometimes yolk prisms can be very helpful with that. Well, fidgets. Why do we need to do things with my hands? Remember that exploratory tool: oral, tactile, communication, vision. I had a roommate in college. He used to drive me crazy. He, brilliant guy, is a neurologist now, but he would have to listen to music when he was studying. And I drove me crazy because when that was going on, it was harder for me to learn. Well, for him, what I think he was doing was he was eating up that communication tool. And what it did is it caused him to have to use a vision. So it caused him to be more a visual explorer. That child that has the fidgets, that's always going here, what I think they're doing is they're eating up that tactile explorer, so they have to be more of a language-based or visual learner. So I think there's a purpose behind it. Toe walkers, that's a really interesting thing. Well, think if I'm growing up and my sense of where my body in space is, do it sideways here, is right here. It's maybe a few inches in front of where I'm at. What I'm going to do posturally is I'm going to lean into it. And what do you know? I'm up on my toes. And so that's another area where sometimes these yoke prisms can be very valuable. Where I put that on, I shift my space. So what I do then is make their upper space appear larger than lower space. And what happens in that space representation, it causes me to step back. There's other reasons for toe walking, but it's really cool when those yoke prisms work because it's like, again, miracle lens. The flickering, like this. We do this all the time in therapy. We use this term called looking soft, which is taking this large area of space. Notice all the space around you. Notice the walls to the side, the floors and the ceiling, the space in front of you. And there's even space behind me that I want to be aware of that. And our patients always have trouble with that. They're overwhelmed by too much stuff, so they learn to shut it down and pay attention to this very small area of space. And so what we want to do is want to get that open. So we'll say, hey, look at this thing, and can you use someone with your eyes to put it together and make the two eyes work together? No. They're looking at the target, and instead of looking at it, they're pointing their eyes behind it, like that word demonstration that we had. One of the tricks to helping them do that in therapy is, hey, look at that thing. Can you see my fingers wiggling to the side here so you can see it? We'll wiggle our fingers out here because that stimulates that peripheral, that retinal collicular pathway that I was talking about. That helps me build that spatial map that I don't see with, but it helps guide me and it helps me to know where to point my eyes, how to move through space. And so I just find it interesting that we do this. So the patient may be behind me and I'm doing this to their sides, or the patient's in front of me, I'm doing it from the sides. And that helps them to open up periphery and they know where to point their eyes more accurately. And then that staring at nothing, could that be that I'm overwhelmed by too much stuff? I'm overwhelmed by vision, so I'm shutting that off so I can listen, because I have trouble looking and listening at the same time. And every child's different, not just children on autism, but every child we see is kind of unique. And that's what I love most about this job is it's kind of like detective work. Why are they doing that? Why are they toe walking? What's going on here? What can I do with a lens or through therapy to modify that software to help them to function more efficiently in the world? The key signs to watch out for, and again, this is just anybody. You've got two groups of kids, the fight or flight system. The fight kids are, man, when I read, my eyes get burnt, they burn, it gets blurry, I get these headaches, the words start moving on the page. That's a child that's going into fight. The flight kids, they're the tough ones. It's like, I jokingly call them the smart kids because they're just too smart to let that. I'm not going to do that because it's going to make my eyes hurt. Oh, what's that? And so they tend to be the avoiders. They'll work for a little bit and then they're distracted by something out there and they want to talk about it rather than do it. Well, that's a way to avoid the stress of up close. They're very sophisticated. They don't use vision because it hurts. Another thing is, my wife called it the homework wars, where that 20 minutes of schoolwork would take hours to get done. It's just a knockdown, drag out fight. They may have symptoms of redness. They may rub their eyes. They may close an eye because the eyes are interfering with each other when they're doing near work or out in sunlight. That's a kick. Everybody squints in bright sunlight. If you see them just closing one eye, think eye teaming problem. And if they're a fight kid where they stay engaged with the target, they may complain of eye strain or headaches. Remember double vision. They won't understand double, but when you're looking at something, does it ever accidentally come apart? Oh, they'll get it. Or do the words move on a page? Those are the two big ones. Do the words seem like they're floating when you're reading? I find that very helpful in screening for problems. Now, these are the sites that I told you about. Great organizations to get more information on this is the College of Optometrists and Vision Development, covd.org. It's our national certification organization. Tons of information there. The Optometric Extension Program is more of our educational wing of therapy. There's great information to be found there. And then our website is part of something called Optometrist Network. It's a group of doctors, primarily doctors that do developmental vision, that have gotten together to put lots of information out there. And if you just put autism and vision, you'll come up with some really neat sites through optometrist.org, and they can direct you to a doctor in your area that does this. A really encouraging thing is this vision therapy visiontherapystories.org/vision autism HTML. I think there's a vision underscore autism HTML. Some great stories on children that have had just incredible success with vision therapy. Some great resources. I love books and I want to give you more. I always recommend this because this talks about exactly what I was talking about. And there's great activities that you can do to help your child. If vision therapy is not for you, it'll give you some ideas to at least get started with it. And a really good book, remember I mentioned those yolk prisms. Mel Kaplan wrote a book, Seeing Through New Eyes, specifically about children with autism. And they talk about yolk prisms in there. So if you want to learn more, you can find these on Google. Unfortunately, the Thinking Goes to School is out of print, but every once in a while you'll see a copy of it come across Amazon. And if you beat me to it, you can get it. But those are great. I'm always giving those out and sharing it with staff to read. Again, this is our contact information. We're more than happy to help. We may not be the office for you, but we can always recommend doctors in the area. One of the neat things about my position is I have a lot of doctors referring me patients. So I kind of know the ones that have a better understanding of this than others. So we're glad to direct you in whatever direction you need to go. I'm low on time, but I wanted to see, Lisa, are there any questions that have come up or anything that I could answer for people?
Dr. Westcott, I think you've been so informative. We don't have any questions at this time, but I would like to open it up to our families. If you have any questions that you would like to ask Dr. Westcott, please type them into your Q&A located at the bottom of your screen. And I see one that just popped up. So here we go. How does this tie into children with both autism and ADHD?
Excellent question. There was a study done in 1999, I believe it was, out in San Diego at Ratner's Children's Eye Institute. So an ophthalmologist had looked at, well, because there's this condition called convergence insufficiency that we talked about, where when I look up close, my brain perceives things further back. So it's stressful for me to stay engaged. And they took a group of children that were labeled as ADHD, and they found that they were 3 times more likely to be diagnosed with having convergence insufficiency. I think 12% of the population as opposed to 4%. Then they took the reverse of that and they looked at a group of children that had convergence insufficiency, and they were also 3 times more likely to be diagnosed as having ADHD. Now, this isn't like a cause and effect type of thing because they're actually different conditions, and you can have convergence insufficiency and ADHD at the same time. But the convergence insufficiency would be considered a coexisting condition. And what's cool about convergence insufficiency, if the child participates in therapy, it just always gets better. So where the ADHD is more this black box, do you have trouble gating mechanism? You'll have to hear my talk on the development of attention, because I can go into that in more detail. But it's a really good question. So the reason there's that the overlap in those groups is the symptoms are very similar. But how I sort through that is, I kind of want to know, is this a child that is a predominantly attention problem, or is that the convergence insufficiency making it hard to stay engaged with up close? And so if it's going to be an ADHD problem, they're going to have trouble paying attention in multiple environments. It's not just, I can't get my schoolwork done. I have trouble getting my schoolwork done, and I have trouble playing board games. I can't sit through a whole video. When I play sports, I'm kind of out in the field playing with the dandelions rather than staying engaged with the game. That's probably more of an ADHD problem. But you treat the convergence problem and they're able to pay attention better, at least up close. The child that really, it's just the homework words, they have trouble getting that schoolwork done, and they can pay attention to board games and things out there, that's probably, I tend to find it more the convergence problem. You fix that, and I've had children that were diagnosed as ADHD, and lo and behold, it was actually the convergence problem. Treat that, they didn't need medication before. And I've also seen children where they've tried medication, just nothing. And then we treat the convergence problem, and lo and behold, that medication that didn't work 6 months ago is all of a sudden like magic. So it's an excellent question, but they are similar symptomology, but different conditions. So there's definitely some overlap there.
Okay, great. And we have one more question. Would a vision screening detect the need for vision therapy?
It really wouldn't. Unfortunately, remember that vision screening, what they're doing is they're looking at distance acuity. And most of the kids, I'm talking 99% of the kids that we work with have very good eyesight. Most of them don't even need glasses to see clearly. but that's completely separate because it's just that one category of optical that they're looking at. Can you see clearly? And you can, most of our patients see clearly, but the eyes don't work together as a team. They have trouble with fixation. They have trouble with visual processing skills. So the short answer is no. Screenings are not a good way to screen for that type of a problem.
Okay, and would ABA therapy include tools to assist in correcting stimming behavior, or would
Yeah.
separate vision therapy be more helpful?
Yeah, I wouldn't necessarily do therapy specifically to get rid of the stems, because that stem is there for a reason. And so as you start working on the eye teaming problem, sometimes we see that stimming behavior diminish or go down. There's usually something else going on there that is actually really warrants treatment. ABA therapy is very effective, and sometimes we need to work with the ABA therapist because where the child's at, we can't get that child to engage in therapy. Sometimes they're not a good candidate for vision therapy, so we have great relationships with occupational therapists, speech and language therapists, because on that developmental scheme, that upside down pyramid, our occupational therapists and speech and language therapists are working on tools that really need to be in place for that child to be successful in vision therapy. Now, if they have an eye turn, then we probably need to start working with them wherever they're at the best that we can. But it's a much more positive experience if the child can engage in therapy and has a desire to improve something, like they want to be better at baseball or better at reading or not get headaches when they read. If they have a goal, much better patient. But ABA therapists are a wonderful tool, and we work with them all the time.
All right, great. Dr. Westcott, I think that's it. At this time, I'd like to turn it over back to Eunice.
Okay, well, this was a wonderful presentation tonight, and thank you, Dr. Westcott, for presenting with us tonight, vision and autism and vision. I want to, this concludes our webinar, and I want you to know that this webinar has been recorded and will be uploaded to Chesapeake Public Schools YouTube page within the next several days. And so thank you for joining us this evening. And remember, families and communities work better together.